I think we're going to go and get started. Good morning, and thank you for taking time to join this webinar from wherever you may be working this morning. The webinar session is brought to you by SOL, an independent chartered chapter of the American College of Healthcare Executives. We are the San Diego Organization of Healthcare Leaders chapter. It's authorized to award 1.5 hours of ACHE qualified education credit toward advancement or recertification. My name is Jack Hallmark. I've been with SOL for many years. I, in conjunction with my colleague, Lydia, will lead the program and events for SOL. And just as a reminder, this event is being recorded. So please put yourselves on mute and let me introduce Lydia.
Hi, everyone. My name is Lydia. I work for UC San Diego Health. I've been with ACHE for approximately 7 years. Again, it's an honor for myself and Jack to be with all of you this morning. In the next couple of slides, we'll be providing an overview of SOL.
Great. Some of you in the audience today are representative of SOL's annual sponsors. We want to introduce you to our current 11 platinum sponsors and 1 gold sponsor, tell you why they are so important to us and why we appreciate them so much. It is very simple. We can't do what we do without the support of our sponsors. SOL members are both aspiring and established healthcare leaders. As a chapter, we are very energetic and ambitious with a lot of dedicated people. Until the pandemic, we put on about 10 programs or events and networking opportunities annually for all our members and the community. An executive program, a mentoring program, a program to help prepare aspiring leaders prepare for the ACHE fellowship exam. All of this activity is capped with our annual conference coming up in December. What you may not be aware of is that approximately 45% of our revenue comes from sponsorship. Sponsor support helps us truly do what we do. So on behalf of SOL, thank you for your generosity. Currently, SOL has approximately 500 members with a variety of backgrounds, experience, and perspectives. We are volunteers-led providers of thinking, learning, networking, and leadership opportunities. SOL is your local connection to the American College of Healthcare Executives. With that, I'd like to now introduce you to our moderator for this event. Barbara Gerber is the founder and president of Devlin Hill Associates, LLC, a nationwide boutique healthcare and senior living mystery shopping company known for its identification and in-depth analysis of patient experiencing challenges in senior living market and sales problems. Barbara provides clients with detailed, actionable insights and potential solutions to often unrecognized process, systems, marketing, and communication problems that impact performance, reputation, revenue, and the quality of the human experience. Barbara actually began her healthcare career as a director of marketing, strategic planning, and physician recruitment of 2 hospitals in Pennsylvania and assistant administrator for 1. She actually led clinical and support departments while working with board and staff physicians to develop strategic plans, launch new programs and services. Always enterprising and energized by tackling new opportunities, Barbara left her hospital leadership position after 7 years to found Devlin Hill Associates, initially offering occupational health and marketing consulting services to hospitals and clinics. Over the years, Barbara's secret visitor mystery shopping service plus marketing and sales consulting have helped more than 60 senior living communities improve occupancy, increase revenue. After a distressing inpatient experience, Barbara turned her passion to the patient experience, conceptualizing, developing, and launching a pioneer nationwide healthcare mystery shopping service for hospitals and healthcare facilities. Since its inception, Secret Patient has helped more than 150 hospitals and healthcare facilities analyze and improve the patient experience. Secret Patient service has been written about in professional and consumer publications, including the New York Times, Wall Street Journal, San Francisco Chronicle, and the San Diego Union Tribune. Barbara has won a variety of awards for her professional work and volunteer activities, including Marketer of the Year, Marketing Excellence Award from the American Marketing Association and Pittsburgh chapter, International Mercury Award, Flashes of Brilliance Service Award, ACHE 2019 Senior Level Regents Award, Soul's 2019 Senior Board Member Award, and Rotary President's Award. Barbara earned her MPH from University of Pittsburgh Graduate School of Public Health and has a marketing certificate from the University of Pittsburgh. She is a LEAD San Diego 2009 graduate, a certified patient experience professional, and an ACHE fellow. Barbara is currently volunteer Soul sponsorship co-chair and a Soul mentor. Welcome, Barbara.
Well, thank you, Jack. That sounds pretty impressive. I never thought about it that way. But anyway, I just need to tell you all ahead of time in the audience that I have a bit of a soft voice, and the computer I was going to use with the microphone was not working. So I'm on an auxiliary computer, and I don't think my voice carries as well, but I will do the best I can. So you may have to listen really closely. Anyway, I'm glad to be here today. Patient satisfaction and patient experience are top of the mind today for most healthcare organizations, from hospitals to physician practices to home healthcare agencies, even to senior living communities. Not only because of the pandemic itself and all the sickness, the death, the disruption, and chaos it has caused, but also because of supply chain, pricing, and revenue complications. Moreover, many of some healthcare executives have compensation tied to patient satisfaction and patient experience scores. And hospital reimbursement is also directly affected by inpatient experience through the HCAP survey. When this was not always so. So a little history here. Most of you probably know this history, but some of you may not. When Notre Dame professors Irwin Press and Rod Ganey started Press Ganey in 1985, they essentially started a new market. They brought the science of solid survey design and administration to healthcare. Press Ganey started out with only a handful of hospital clients. But each year over the next decade and a half, more and more hospitals saw the value that could be gained from tracking their patient satisfaction and comparing it with those of other similar organizations. At that time, also a number of, like 2 or 3 other big organizations joined this, and NRC, Gallup, and PRC emerged and grew. So during the same period, the survey subject sites expanded from inpatient units to emergency to outpatient to ambulatory care centers, medical practice departments, as well as other areas. And the sophistication of the data grew. The sophistication of the analysis and reporting continued to increase. And survey companies began to offer healthcare organizations advice on how to improve their satisfaction scores, their patient experience scores. This is about when I came in and started my business, and because I realized that there were a lot of things that even in the standardized surveys, they could not pick up. So that was the reason for Devon Hill Associates. The federal government first became active in patient satisfaction in 2002, and then we come around to the HCAP survey in 2005 and 2006. And around 2005, hospitals began to receive financial incentives or pay for reporting for participating in HCAPs starting in 2007. And not surprisingly, eligible hospitals' participation rose significantly in that year and since 2012. HCAPS is currently under intense scrutiny, but any substantive changes are unlikely to occur. So it took over 20 years for the interest in patient satisfaction and the patient experience to go from a whisper to a roar. But in a short period of time, in less than 3 years, the pandemic has forced us rethinking what patient care and what the patient experience really mean. And suddenly, patient journeys and patient satisfaction metrics that have been telling providers and patients what patients want and expect for years have suddenly changed. In a short period of time, as the pandemic has overwhelmed lives, hospitals, and livelihoods, including mine, for patients and the staff who take care of them, it has forced rethinking what patient care and what the patient experience really mean. Although the basic patient experience principles still ring true today because the pandemic has disrupted lives and people's livelihoods, disrupted how hospitals operate, how medicine is practiced, and how care is delivered, the question frequently arises: how do we take the current situation and the lessons we have learned during the pandemic into the future? How do we take everything we knew and practiced for 15 or so years and everything that has now changed and design or redesign a patient experience going forward? What should the strategy be? What should the plans be? What should the design be going forward? Where are the opportunities? Jack, the picture slide with Sun Tzu. Okay, when I think about these challenges, it reminds me of a quote from a famous Chinese general. No one is sure if this general is real or fictional, or maybe he's an amalgamation of various journals. But he wrote a famous book called The Art of War, and he's famous for a variety of different kinds of quotes that make a lot of sense. And one quote I have often personally thought of, especially lately, is in chaos, there is opportunities. Because chaos, as challenging and as disastrous as it may seem or be, also brings with it opportunity. So when we look at the pandemic and the chaos being produced by the pandemic, we can think of it also as an opportunity to do something new or different. So if in chaos there is opportunity, so the important question we need to ask ourselves is, what are the lessons that we have learned that will become the opportunities of the future? We have an opportunity here today. We are fortunate to have the opportunity to spend the next hour or so hearing from 3 people who have been intimately involved in the chaos of the pandemic. What are the lessons what are the lessons they and their organizations have learned that they can share with us and can carry forward? And how do we design the patient experience in this new COVID and post-COVID era? What are the opportunities? What should we go forward with? What should we leave behind? I expect we will hear about some of the lessons learned from the perspective of the patient and the provider. As Sonia mentioned to me, everyone has learned something new during the pandemic, whether it's about the virus itself, what's necessary, what's not necessary, how different people respond to the risks of the virus, the vaccine, and the mask mandates. There are many opinions upon these subjects. I see them in my very own family and argue about it all the time. We don't have any time for any extensive discussion in an hour, but we will ask our speakers to answer many important questions. Our panel today decided that they wanted to share the information with you by jumping right in with a question and answer format. So that's what we're going to do. But first, let me briefly introduce our speakers. Jack, I see you have the speaker slide up. First, on the left is Dr. Sharif. Dr. Sharif is a Chief Medical Officer and Corporate Senior Vice President of Acute Care and Clinical Excellence. Dr. Sharif is a board-certified emergency medical physician and a pediatric medical physician with an MBA, so you can be sure that she understands the business end as well as the clinical end. Prior to joining Scripps, Dr. Sharif ran the emergency medical department and 4 urgent care centers for Rady Children's Hospitals. And in 2018, Dr. Sharif was chosen to lead Scripps activities to enhance and maintain an exceptional patient experience. Her work with patients, physicians, and staff has resulted in significant improvements in patient satisfaction. You can watch some of Dr. Sharif's presentations on YouTube, but I encourage you to watch the one made 4 years ago at the HIMSS Southern California Conference. Next, we have Leslie Wilson. And Leslie is the Associate Chief Experience Officer at UCSD Health for the past 6 years. And she is intimately involved in creating the vision and strategy for the experience throughout the health system. She oversees research, design, and implementation of initiatives and programs that improve team member, patient, and guest experiences. And she leads operational areas that focus on patients and guests as well. She is also responsible for the organization's Care Navigation Hub. And at the granular level, Leslie is also responsible for analyzing patients' feedback. Leslie is also responsible for the data, that patient feedback, and the data that she's analyzing contributes to the design, development, and implementation of the goals and objectives throughout the health system. Leslie was instrumental in implementing UCSD's Leading the Way, an experience framework for team members. Prior to UCSD, Leslie was with Sharp Healthcare for 16 years in various roles, leading operational areas that supported the Sharp experience. And finally, but not really finally, we have Sonia Rhodes. Sonia Rhodes is the founder and leader of the Experience Lab. The Experience Lab is described as an incubator of ideas and an accelerator of action, created to bring experience, design, and cultural transformation principles to the healthcare industry. While she was at Sharp Healthcare, Sonia was the first health system executive in the nation to launch and lead organizational-wide experience transformation that became known as the Sharp Experience. And I heard about the Sharp Experience when I first moved to California from Pennsylvania. The Sharp Experience resulted in increased market share and net revenue earnings. Sonia also conceptualized, designed, and directed the Sharp University, creating a comprehensive learning platform for staff. And in 2007, Sharp earned the Malcolm Baldrige National Quality Award for Organizational Excellence. Sonia is also executive producer of TED Youth San Diego and co-author of The Complete Guide to Transforming the Patient Experience, which is available on Amazon. So let's start our conversation today with a few important questions, and we'll have a number of questions, and it's going to be almost in a round-robin format, meaning I'm going to go from one to the other, asking sometimes the same question of all three, sometimes of just one or two. So Leslie, let me start with you. What is the experience that you think the consumers, patients most want and expect from hospitals, healthcare facilities, or organizations right now? What do patients want to feel from their care team and the organization right now?
Sure. Thank you, Barbara. And so I'm super excited to be here to share some of our kernels of wisdom around the experience work, particularly during this time of the pandemic. And at UC San Diego Health, we were really fortunate. We've been on a journey for about 7 years now. And we designed Leading the Way, a framework for how we think about our experience work. And we built our framework around experience intentions in the form of an acronym, UCSD. So unifying, coming together, connecting, making those connections, seeing how we view the world, and then discovering. And so as those UC San Diego intentions came to life in our journey, they've really become design tools and decision filters for how we approach experience. And so coming into, and not just, I want to clarify, I know the topic here, it has been patient experience, but for us, it's really the team member experience as well as the experience we create for the patients and guests who come into our organization. And so we have used these lenses to really understand what patients want as they come in. We design through those lenses to a feeling that we want to create, knowing that we are impacting, we are making memories, both positive, we know that we're in the business of saving lives, but how we transform and interact with those patients when they come into our organization leaves a lifetime memory with them. And so when we thought about designing for this experience during the pandemic, it really amplified our team's use of how do we design to a feeling. And I think, specifically to your question, what we understood throughout the pandemic is patients wanted to feel that their fear was reduced, whether that was from a quality standpoint, a safety, they just wanted to have reduced fear and increased confidence and trust in their health system. So with that feeling, whether it was designing an operational process of how to move them through a drive-through testing, that was one of the innovative things that we launched during the pandemic. We always had that lens of how do we want the patients to feel? How can our processes align to ensure that feeling? We accomplish our tasks, but also create that important feeling with that intention. Certainly, allaying those fears translated into making sure that we were proactively communicating with them. Every touch point was how do we create a safety net so that they could continue to trust that we were creating an experience where they could still access healthcare in a safe and confident manner.
Dr. Sharif, do you have anything else you want to add to that from Scripps' perspective?
Yeah, absolutely. Leslie and I actually sit on a West Coast collaborative patient experience platform, and it's great to see Leslie here and Sonia as well. And so very similar themes that we're seeing really across the country. Leslie, you mentioned the fears, and that boils down to feeling safe, right? There was a lot of miscommunication initially, just from the media, from CDPH and CDC. And so we felt that we wanted to be the voice that they could trust, be that trusted voice. So part of what we have found that patients really want and expect is even heightened around seamless care, right? And so we have worked very hard to align our inpatient work and our ambulatory work, and I'll tell you more about that in a second. But when they get discharged from the hospital, we have a lot of patients who have ongoing symptoms from COVID, right? The long COVID patients. And so really coordinating their care is one thing that they expect. They don't want to get lost from handoffs one to the other. So that's become a very important part of our daily work. And what they do want is to be kept informed even more now because they don't have visitors in the room, right? We've had some restrictions. And so what we have found is that we have had more deliberate conversations. And I say that for a reason. We are so much better now on patient experience than we were actually before COVID, which is fascinating that our scores actually went up. When we started our journey in 2018, our Scripps hospitals were 55th percentile, which means that 45% of hospitals were scoring higher than we did. As we finished our fiscal year, which just ended September 30th, we actually ended at 82nd percentile, meaning only 18% of hospitals score higher than we did. And I really attribute that to bringing our quality work, handoffs, some of the other work that we've been doing, and patient experience coming together under one platform, quality and patient experience. It's not quality here, patient experience over there, right? And so the deliberateness of these conversations, we go in and who can we call today, right? And we coordinated with the families that couldn't be there. We went in on purpose. So we're rounding with purpose, right? Because we didn't want the nurses to go in and out of the room for their own safety. So we were coordinating their care so much better than we did before. we used to call it playing whack-a-mole. You go in, you answer one question, then you go out and then do another, and you keep going in and out of the room. It became more organized. And so I'm actually, I love that our scores are higher, but I also feel like there's a reason. So what we don't want to do is go back to the old way, as hopefully we come out of COVID after the holidays. My fingers are crossed that we don't see what we did last time, that we don't go back to the old ways, that we keep up what we have learned about our communication skills, right? We can do this. We can do even better going forward. On the quality side, we have put together what we call sprint teams, focusing around specific problems. So congestive heart failure, for example, ongoing pulmonary disease, chronic obstructive pulmonary disease, infections. We actually found higher rates of central line infections and urinary tract infections in our COVID patients. So how do we coordinate all of that? And that's what the patients want, right? They want us to make sure we're coordinating everything. So these sprint teams are designed to take a problem and solve it in real time, not take forever to solve the problem and process it to death with sticky notes all over the place, but solve the problem. And that has helped with that seamless care, right? Because we make sure we hand off to our ambulatory team. So I think their expectations are that it's are going to be around them now. Remember, we used to do a lot of things that were centered around us. Hours are when it's convenient for us. And so even UCSD, I know you've put in a lot of Health Express clinics as well that are convenient for the patient. Telemedicine, oh my gosh. We had maybe a handful of telemed visits before COVID hit. Our peak was 3,000 visits in one day. And it took us, why did it take us so long to get there? That's what the patients have been asking for a very long time. Make it convenient for them. So they want safety, they want convenience, and they want to make sure that we know about them when they come into our care. So it's not starting over from the beginning every single time. So I'll stop there. Lots to talk about on this subject, which is why we didn't want to do slides for you. We wanted to talk you through some of our challenges and solutions.
Sonia, since you work around the country, around the nation, you get to talk to a lot of different organizations, not necessarily, excuse me, in California. Are there different skills, strategies, or tactics that you have found that we have not talked about right now, that you're finding strategies or tactics that are being implemented as a result of COVID? Leslie and Dr. Sharif have mentioned two of them. Is there anything else that you have found in your talking with other organizations around the country?
I do think that we're fortunate to have these two experienced leaders right here in San Diego sharing what they've been doing across this pandemic. San Diego has always been in the spotlight and at the heart of the experience realm for our industry. So it's really fun to be able to hear what's happening right in our own neighborhood. And I would just perhaps and what was described. I think across the country, what became more clearly in the spotlight is how much our patients and our colleagues wanted to be known, to be seen, to feel like they matter. They wanted their needs anticipated and designed for, rather than feeling like they're kind of having to fight or find their way through the experiences. And I think that's been the case for a long time. It's what we've been designing for a long time, but that heightened opportunity of the last 2 years has really taken that to new heights in really, really exciting ways. One of the really important principles of experience design is the powerful principle of orchestration. And you just heard that from both of our colleagues here, that creating a more orchestrated experience that has a clarity of intention, the feeling we want to impart for everyone, and then seamlessly creating that from touch point to touch point to touch point so that folks are guided through their experience rather than kind of having to find their own way. And I think that's been the big aha. And then lastly, the absolute extraordinary opportunity for the interplay of our focus on the human side of our experience and the marriage of our technical side to amplify that. So some of the most incredible transformations that we saw were digital advocacy, where new ways through text chat streams with live bodies could be getting thousands and thousands of patients the information and access they needed. There are some organizations across the country that have really been leading the way in that marriage of humanity and technology, and I think setting us up for what's to come for the future.
Any other comments back again from Leslie or Dr. Cherie? Okay. How do you think, I'll start with Dr. Cherie. How do you think these lessons, how are you going to carry them going forth as you plan about the patient, as you plan the patient experience and your strategies or tactics and training and so on? How do you plan to, you've done this now for a short period of time, but you obviously want to weave that into the organization. Are there specific plans you have as to how you're going to do this? I mean, is this just a stopgap matter, or how are you going to weave it into the organization?
So it's a great question. We have two different teams. One is called the XOps for fun, Experience Operations Council. We have an ambulatory one and we have an inpatient one. And so we just revamped both of those committees. We just met last week as we start our fiscal year to take the learnings really from the last 2 years and make sure that we take them forward. And so we're actually going to be rolling out a self-assessment survey based on the patient experience survey that we ask, our staff, our patients to fill out, so the staff know what the expectations are going forward. Communication has been highlighted so many times, but it's important the patient understand the purpose of the medications, right, and the side effects. Otherwise, they won't take them, then they bounce back, and you get a readmission out of it. And so there's a cycle here that we want to break. And so we have learned that through what we did just the last 18 plus months, was that when we communicate directly to the patient about what the expectations are, what their condition is, why they need to follow up, all of those things that we should have been doing, frankly, better before, we want to make sure we take those lessons forward. So we are taking that and we are regrouping again after this difficult year and just refocusing on staff. I think one of the important lessons that we have learned is absolutely being more patient-centric than perhaps we have been, coordinating their care. We have patient care assistants now that we had pre-COVID, but going in and doing purposeful rounding, which was, again, we're supposed to have been doing, but COVID has reminded us that that's so important because we don't want to be in and out of the rooms. So we go in, we absolutely make sure the patient gets up and goes to the bathroom while we're there already, so they can minimize their call button use, which is also, hard because they don't have anybody sitting with them to come and get a nurse. And so we want to take all of those lessons and really drive them forward. So that's what we're doing right now. Literally, as we speak, we're putting together a self-assessment surveys. And these surveys, the staff take it on their own. It's not punitive, but we ask them, do you do these behaviors? Are you always communicating about your medications? Do you make sure that the call button is answered in a timely fashion, right? Are you explaining things to the patients in real time? And they take it themselves, and it's based on the survey. Ambulatory is a different one, inpatient has a different one, and they take it themselves. And my ask is you just do one thing that you aren't doing all the time consistently and start there. Otherwise, it's overwhelming. You can't fix everything. But if you start with one thing that you aren't doing on a consistent basis, that's what they want to focus on. So we're going to be sending that out. We collaborate the results, and then we see where are weak points, where are staff telling us that they don't focus. If it's we don't get to the call button in time, okay, let's put some parameters around that. And so it's actually a fun exercise for staff to do, but it also gives us a lot of feedback from our front lines as to where we need to improve.
Are you planning, Leslie or Dr. Sharif, are you planning on changing or revising, not HCAPs, that has to come from a higher power, if you will, but in terms of your own patient satisfaction surveys, the metrics that you collect, are you planning on revising that so that you can now measure yourself in a different way or for different things than you did before as part of your plan for the future?
Not right now, because we get value-based, everybody knows value-based purchasing is a government program. We are financially on the hook for HCAPs, whether we like it or not. That's 25% of that program. And then there's a readmissions reduction program, which is a punitive metric, as is hospital acquired conditions. So we didn't really want to start a whole nother survey when we know that is absolutely what the government holds us to. And we can do better. Those are questions that we actually need to be doing. Do you have the follow-up when you go home? Do you understand what we told you? Those are basics, but we are moving to some people already have this, but we haven't started it yet, and we're excited to kick it off, is a natural language process program, which can just consolidate all of the comments, because there's a gold mine in the comments, let alone the scores on the patient experience survey, never, sometimes, usually, always, but in the comment section itself. And so what this program does is lump them into proper categories. So is it facilities? Is it food nutrition? Is it really a physician communication issue? So that we can delve a little bit deeper into what our patients are actually saying, versus the current process is manual, right? Everybody on the unit gets their surveys, they go in, they have to read every single comment and try and do this on their own. But so that's going to change our focus as well as we go forward, so we can fine tune a little bit more into what the patients are telling us. So that's our new strategy.
How about you, Leslie?
Sure. We aren't changing any strategies around the data. To expand on what Dr. Sharif said, it's really the gathering of the voice of the patient to give us directional, no matter how you ask the questions, they're the important things that we always design to, so that communication, the cleanliness, the quietness, regardless of how the questions being asked, they're the most important things to design to. And so the comments, I agree, the comments are the stories that help really propel us in conversation as we support the teams in improving their experience processes based on that patient feedback. Those patient stories, they are our second set of eyes, and looking at those comments and listening to that voice of the patient through their perspective really helps us solidify that partnership with our teams to design an experience that really meets those patient needs. And so I agree on the natural language processing and the value of the comments, both from a directional standpoint, as well as that opportunity to reward and recognize our team members and providers. I'm always stunned how many patients specifically call out the names, and especially during this time of the pandemic, that remembering the impact that those physicians and the nurses, in absence of their loved ones, created not only an amazing care experience, but that human experience for them when their loved ones couldn't be with them. And so those comments are rich for those stories and gratitude.
Sonia, would you like to add anything to that?
Yeah, I would just love to say that the other piece to those comments has helped real-time rapid transformation in a pandemic in a way that were probably some of the perhaps less visible previously. Things like folks without a family member not being able to attend to their own meal, not being able to open the little juice carton or whatever it might be, not being able to reach the plug for their phone, that desperate need to stay connected, but because of the situation they were in, unable to reach, so that these amazing, important roles in our organizations have been changed dramatically. In many organizations, housekeeping and food service now have even more heightened relationship roles where they're not only there to clean the room and attend to that side of things, or not only to deliver the meal or take the order, but to also really create a relationship of what else can I do to help you while you're here alone without your family members? How else might I be able to put something in your reach? And the comments instantly, we started to first see the frustration of being alone. And if you had a loved one who is alone in the hospital across these last 2 years, you know how scary that is to not be there with them and for them to be alone and wonder, does anybody know what's happening to me? And so to have everyone on the team understand not only their everyday role, but that role of also extending their experience, their love and respect for people has been incredible. So now we've really elevated the roles of our keepers of the house and of our food service team members, environmental team members to play an even more important role in their patients' experience. And I think that's very exciting.
Barbara and Sonia and Leslie reminded me about one other thing we are doing, we use a Cipher Health 48-hour discharge phone call system because it was just better than having our staff trying to call people and do that 48-hour follow-up. And so that voice of the patient is so important in real time to find out, okay, what are we missing? So with the only tactic different besides the things we've talked about is asking some different questions. So we all know what our low-hanging scores are on our surveys. Ours happen to be responsiveness of the call button. So, but we've never been able to get our arms around, but what is it? Where we've got patient care assistants, we're doing all the, all the stuff. What is it? What are we missing? And maybe we just find that the expectations are unreasonable, right? If you push the call button, you expect somebody here now, that's not going to happen. And so how do we change patient expectations as well? But trying to figure out what are we missing? The quietness is always one that bothers all of us, right? How do we make it quiet at nighttime? What do we need to do? So getting that real-time feedback. And changing as your scores go up and down, changing those 48-hour questions so we get real-time feedback before the survey even comes in, right, can help us make more immediate adjustments and share that across the system for learning. So that is an additional change in just the questions. We've been doing Cipher Health for several years now, but again, adapting to every time you improve something, let's go to the next one that we need to work on.
Any other comments?
Barbara, can I just add, we were doing our daily engagement system huddling prior to the pandemic, a system for readiness and huddles that tier up through the organization all the way to a tier 5 with the CEO of the organization. And so one of the categories in our readiness is experience, team member and patient. And so we have really amplified our ability for team members at the tier 1 front-facing level to escalate patient issues or opportunities to remove barriers to the experience real time. That's another channel for voice of the patient that's been very successful, and not even having to wait for real-time surveys, but having team members really identify and then circle back and make and implement immediate changes. So that visibility and strategy will be something we definitely continue and amplify in the future.
I have to add something because it does seem appropriate, but I'm not sure because it's about me. I don't know whether you knew that what I did was we sent people posing as real patients. They became real patients, and they gave the exact feedback that you're talking about. It was controversial. I don't intend to do it anymore because I feel that given the pandemic and everything that's gone on, that I wouldn't feel comfortable doing it. But it's always been my belief that what you're talking about, which was what we did, was a very important part of the patient experience metrics or feedback that was missing. And I'm really delighted to hear that that's what's happening. So anyway, I have to put that plug in there. It's not a plug because I'm not doing it anymore. So, okay. So I have to just read here where I am. Okay. Are there any new skill lessons for staff or changes you planned or executed as a result of the lessons you've run? Now, you've said some of them, but I'm wondering if there are some skill lessons that you can share with the audience of things that you did a little bit more specifically to bring this about. Sonia, you might have that. Are there any particular kinds of lessons that you can provide to staff with respect to skills that can be developed in order to be able to do this more easily, quickly, comfortably, and so on?
Yeah, yes, fabulous. There are an extraordinary set of experience tools, skills, principles that every individual can use. I think the most important lesson maybe we would want to speak to across the industry, and you're hearing it real time right here with UCSD and Scripps, is that it's very difficult for us to create the kind of meaningful and memorable experience with our patients and their loved ones if we haven't first started on the inside of our organizations by creating that meaningful and memorable experience for and with our colleagues. And I think that that's where that depth of focus, the kind of doubling of efforts in organizations across the country is on that team member experience right now, because that skill set of how we experience each other is what translates to how our patients and guests experience us. So right now across the country and in some of the largest multi-state systems that we work with, their focus is fully tuned to that experience of their team members and their providers, and putting those tools in the hands of those folks so that they become the architects of the future of their organizations. And I think we right now partner with an organization that has 1,000 leaders fully immersed in a new skill set and a new tool set around their culture and experience. And it's so exciting to see these folks designing what they know will be the future based on everything they've learned and experienced these last 20 months. You know, yes, also based on their history of everything they did before the pandemic, but this is that moment to really a springboard moment to leap into the future. And so many organizations from really week one began to split their leadership teams and their focus. Some were focused wholly on our pandemic response, and others were focused on designing the future by taking that learning and putting their team members into design salons real time as they moved forward. And now they're kind of ready to bring the future to life. So there are numerous large skill sets of actually understanding what we would call an inside out approach, that we have to focus on our team members to be able to create that experience for our patients. And then the last thing I would say, and I think we're all feeling it, is building in time for our folks to have respite, to heal, to be able to simply be and breathe. And so those, I know they sound really simple, but those are big skills that are being taught across organizations, building into how every single meeting starts with 3 minutes of breathing, how every meeting ends with appreciations for folks, that they're building in a way to not set ourselves up for, you know, a continuous exhaustion that we've been living through, and learning from our own people what matters most in that regard.
Are there ready-made tools, if you will, that can be helpful, or does every organization have to create their own from scratch?
Well, I think that's a great question. I'm sure there are lots of tools that people can have access to. I know as an experience lab, rather than speaking directly to tools, we speak to principles, that there are universal principles of experience design, and we teach the principles so that then organizations can design their own tools and skills that work just for them. It gives them that ownership in a way that it does not feel like another thing to do. What we're trying not to do when it comes to experiences is add more on people's to-do list. Experience is a way to be. And so helping folks in that being space, giving them the opportunity to understand why we want to design with intention our experiences inside and for our patients and guests, and then how everyone can be an architect of those tools, those skills, and those experiences. But it all comes down to the feeling that we want to impart and helping people understand that feeling space. And I know that sounds funny because we probably haven't spent as much time across 20 years really talking about the feeling. We heard Leslie describe that as the way that they lead their experience, but a feeling is our design tool for how we create skills and methods and approach. And if we all are clear on the feeling we want to impart in those moments that matter, then those skills are designed to that feeling.
Leslie, what do you anticipate might be the biggest stumbling blocks to moving forward with what you've learned and the things that you'd like to do? What will be the biggest stumbling blocks? Is it?
So I always look at them as opportunities to really amplify what we've learned. Like Dr. Sharif said, I don't think we're ever, there are things we never want to go back to, right? We just want to amplify and take some of those positive lessons, those implementations that we've learned during this time. And so our team is really thinking about, how do we help renew, reflect, heal, whatever we're calling that, to what Sonia described. How do we support our teams as we move through and out and forward into a newer future that they're building together? And so I think we're just, I don't see these things necessarily as stumbling blocks. It's how do we use our experience that we've gained during this time of the pandemic to build that new future that we are desiring.
How about you, Dr. Sharif? What are the stumbling blocks that you might anticipate?
And I agree with Leslie, they're all opportunities, but Sonia, you touched on something which I was going to touch on, so I'm glad that you kind of set me up for this, is that right now, and everybody's talking about burnout and pandemic fatigue, this is more than just fatigue. This is true emotional and well-being. This really has to be addressed first and foremost before you even talk about patient experience, right? Because if you have a truly exhausted staff, and we're seeing that, and the turnover, people are retiring right and left because they thought they wanted to stay, get through the pandemic and help us out. And frankly, the patients we are seeing right now, and this is the elephant in the room, some of them are really cranky. And I'm saying that very nicely. Some of them are calling our staff liars when they tell them they're positive for COVID. They're demanding when they want their visitors. And so this is not what our team signed up for. To be honest, when the pandemic first hit, people stayed on, they picked up extra shifts because they were being treated as the heroes and they thought they're making a difference. Now we have this shift, and our patient experience scores frankly plummeted after we saw this last wave of patients, the fourth wave. We were doing great on our metrics. And when August hit and we had our peak patients, those surveys are coming in and the scores have gone down. And so we're seeing a whole different population, which I'm hoping after the holidays, we get back to our normal, nice population. So staff, we have to address how they're feeling. And so last year, actually a year and a half ago, we put in the RISE program, which is resilience in stressful events, the program through Johns Hopkins. And that is a peer-to-peer counseling program. A lot of times, staff doesn't want to call the psychologist, they don't want to do that, but they would like to talk to a peer, maybe before they go home, because frankly, my family's tired of hearing about COVID. I'm not allowed to talk about it at home. And so, where do we decompress, and how do we offer that support before they go home with a bad case or whatever it is? It doesn't have to be COVID, it can be anything. And so having that peer-to-peer support, the physicians, we have a whole physician team as well. Now the number of calls aren't large to the formal program. There's a lot of informal coaching going on because we've advertised, these are your leads, these are your peer responders. And so that's one thing that we have to do. The other one is we're actually putting together a class for de-escalation because we have seasoned doctors coming to me saying, these patients and their families are really tiring us out. And these are trained doctors. I'm an ER doc. I'm used to difficult people. I do this all the time. But when it's constant barrage over and over and over again, they're asking for some help. So we're trying something novel. We always try things, that are a little maybe off the beaten track here. But we're putting together physician and nursing teams. And so we're going to have that training on the 3rd with our security officer and one of our psychologists. So how do we set boundaries? How do we use some key phrases? And if you need to, do you have to substitute a different team in? Because, sometimes those patients just don't like what you have to say, and they don't like me or whatever it is. But how do we give those tools to the staff? So it'd be exciting to report back after that. So we've got 2 doctors, 2 nurses from each hospital coming to this training. We have some ambulatory folks coming as well to take this class. It's a live class, virtual, to give them some additional tools. And some of that is just a reminder that this is not personal. When you have these angry patients, or the repeat frequent flyers that come back over and over again, and they're berating the staff, it's not personal. And for me, that's probably the hardest thing, because we want everybody to be happy. Even as an ED doc, I want people to be happy, right? And so when you're getting these slams, I have to remind my own self that this isn't personal, right? We've all received emails, from upset staff, right? And I do tend to take those personally because I thought I'm doing everything I can for you guys. Is that not enough? But taking a step back and realizing that a lot of that is coming out of fear, right, for the families they're acting this way. And how do we remind ourselves that it's not personal? So that's what we're working on right now, because before you get to patient experience, staff safety, staff well-being has to be foremost.
Sonia, do you have anything to add? Sonia, do you have anything to add to that?
The only thing I would add, and it's interesting how our pandemic gave us new places for our experience to come to life, and how quickly when those places start to dissipate, maybe the processes go with them. But one of the things that we loved so much in the beginning of pandemic, when team members would have a screening process, right? You'd come in a team member entrance and there'd be a screening process on the way in and a departure process. And many organizations built right in their well-being into the arrival and departure of team members every single day. Leaders were at those spaces and places. There was a way that they were greeted, conversations were had, and it was a way to kind of bolster people on the way in and also have a safe space for the decompression on the way out. And many organizations had entire processes for meditation from the door to their car, playlists for when they arrived in their car, what they would play on the way home, as a way to really guide their team members through this very challenging time. And I think that when the screening went away, unfortunately, sometimes those really important elements that were built in also dissipate. So I would say let's instead of letting some of that slide, we need to find new places and spaces for us to be gathering our team members, to be connecting with them, to give space for their stories. We're hosting in many organizations story salons, virtual, and some are in person in a safe way, where they're having salon discussions about the trauma they've experienced, about their hopes for the future, and knowing that it's okay to talk about those kinds of things. So I think there's, how do we continue to build it into the way we do what we do? That had such a positive impact. And then how do we also create more space right now so that we can really learn from this trauma and figure out how to not have that happen when the next challenge comes our way?
I have a question. We talked a lot about the things we would do and what we're doing. What are some of the things that you plan on leaving behind, if you will? Things that you've always done because that was something you just were expected to do, thought you were expected to do. Are there some things that you will leave behind? I keep thinking about when I had to go to the emergency room and how I sat in my car for a while instead of sitting in the waiting room. Are waiting rooms going to be eliminated to some degree or be channeled somehow? What do you think that you've always done that you might leave behind now because of COVID and the pandemic? Any one of you?
Oh, well, I would say that, and I know for sure because our sprint teams have been working so well. What I don't want to go back to is the slow way that we always used to do things. It was process, process, process. You have to have an A3 for everything. Even if I already solved the problem, go do an A3. So I don't want to go back to that. I think we have proven that we can pivot really quickly with the daily changes that we've had with COVID guidelines, testing guidelines, up and down, up vaccines, up and down. We have learned how to pivot. And my hope for our team, we're rolling out new sprint teams to address some of the things that we need to work on next, but that we don't go back to that. And that is my mission, is to make sure we don't go back to that where it takes months and months to get something done. We have allowed perfection to be our enemy, right? We want it to be so right that we never get anything done. And so my challenge to all of our teams is that's not your mission right now. Let's try something. Our doc mantra, try fast, fail fast, right? And let's try and let's get moving. And then we can fine tune as we go. But if you get paralyzed in trying to make a process, it's never going to move. And frankly, that I do believe is what is contributing to our increase, our rise in patient experience, even through some really difficult times this last 18 months. So that's my hope, that we don't go back to that, in addition to a lot of things that we've talked about.
Perfection is the enemy of the good. Is that what they say?
Absolutely.
Leslie, how about you?
Sure. I think that the patient self-service via technology, so through our patient portal and even how we took them online to the vaccinefinder.org, et cetera, to do their own scheduling, I think has really propelled utilization, just huge numbers of patients signing up for and more frequently using the tools, mobile tools to communicate with us. And so I think a comfort level was developed during the pandemic, born out of necessity, but really establishing that as an option. So certainly want patients to call us if that's the way they want to interact with us, but really making healthcare move forward to catch up with some other industries as far as the tools that are available for that sort of self-service piece of it, and just want to continue to amplify and improve those tools.
Sonia, what do you hear around the country about what?
Well, Barbara, you mentioned waiting rooms, and it's really interesting. We do work with organizations that are primary care clinics, with large footprints, and they're building new. And the brand new clinics that are being built are not being built with traditional waiting room spaces based on the lessons of this year. They are building in a combination of digital and sort of arrival experiences, and they come and are guided right to their exam rooms. And exam rooms, interestingly, and one of the organizations we've been partnered with in their design, also are built in with a space in every exam room for a virtual visit with the right background and everything that a provider will need, so that they can build virtual visits into the workflow of the day in every single space that they have. So it's been really interesting. I think for a long time, we've always said, nobody wants a waiting room, right? We've named them lounges instead of waiting rooms, just to kind of change the feeling of those spaces. And now finding, certainly on the clinic side or primary care side, that the elimination of that waiting space in a traditional sense, we're definitely finding. The other piece that's really interesting, you guys talked about virtual and how critical our virtual visits have become, and how, as patients, we love the opportunity. As I like to say to my providers, if you're not going to touch me, I don't feel like I need to drive in. But if you're going to need to touch my body for some reason or do something, great. But otherwise, let's stay in this space. But the other virtual that has started to come to life is virtual live concierge. So the opportunity to have a live concierge for those routine, repetitive, kind of redundant procedures that are happening in our places and spaces, and folks that struggle sometimes with very laborious written instructions, or they have trouble getting onto the portal, whatever it might be. You can now have a live person 4 times a week that's talking people through their colonoscopy prep, or talking them through their surgery prep, or talking them through on a Zoom how to best use the portal. So they've got a real personal guide, but they're using technology to do that rather than it having to be one-on-one. Every day there's a portal guide Zoom call that people can join. So I love the marriage of that virtual for more than a visit.
Jack, how are we doing in timing here in terms of getting questions from the audience?
Really good. I've timed as we have 8 more minutes. And so at 15 after, I'm going to give you that heads up. We need to transition.
I have one sort of maybe philosophical question. I'm not anthropological. I never studied anthropology, but how has all of this changed in general? And maybe this is not a 1-sentence answer. It probably is not. How has it changed your culture? Leslie, how's it changed? How has COVID changed your organization's culture, or has it?
In my opinion, we've become a more unified team, really, and we've become more connected with one another. So especially not, and I'd have to say even with the community. So we have a experience operations team here, and during the early parts of the pandemic, we facilitated over 23,000 meals that came in from over 200 donors here in San Diego for our team members. And that outreach and the cards and the letters that came in, and it was huge in terms of being able to display those, as Sonia mentioned, that arrival of team members for that screening process, the visibility of seeing the gratitude from the community, and those in all our areas being able to share a meal that was provided out of gratitude, created an even stronger connection with the community support of our teams. But I believe we've become more unified, more transparent, more connected with one another in this important time of the pandemic.
How about you, Dr. Sharif? How about scripts?
Well, you saw me go, yay, because that's exactly the answer that I was going to give. We have become so much better aligned from emergency department, inpatient, ambulatory, and partly through our operations briefings, because we bring everybody together and we know exactly what's going on in different areas. I do think that I put together we had a management meeting last week, and I was thinking about all the words used to describe healthcare workers today, right? They've shown fortitude, they have shown innovation, empathy, resilience keeps coming up over and over again, right? Creativity, compassion, courage. And the other one I thought was empowered. So I put together, it's called fierce, because all those words add up to the word fierce, right? But I do believe that we've become more empowered for people to bring forward ideas and suggestions that they may have thought, well, that doesn't make any sense, let's not do it, because innovation has been everything about these last 18 months plus, right? Is how do we do things a little bit differently? So I think unified and everybody having a voice in the solution, because a lot of these solutions came from the front lines. Having the baby monitors in the room, for example, who would have thought that was such a brilliant idea when we could go in and out of the rooms as much? Simple things, right? And so I think that they feel empowered, and I hope they do. Fierce.
Sonia, what are the 4 most important questions that an experienced leader should be asking right now?
Thank you. I love that question. For us, there are 4 thematics when it comes to experience design. So 1 is leading. And then the question is, what is your experience intention? How are you using that intention as your design tool and your decision filter? Not every organization is clear on what they're aiming for their experience, which means it's really hard to design to something. And experiences we want to be by design rather than by default, just sort of the way things come. So what is your experience intention? And that can be as simple as we said earlier, what feeling do you want to impart? If there isn't an organizational intention like what Leslie described, unifying, connecting, seeing, and discovering, let's just think about the feeling we want to impart for this day, for this moment, for this interaction, and design to that. The second question is a thematic around looking, using all of our senses, which I think we've really seen our teams use their senses in a much more amplified way across this time. They've noticed details, large and small, and then done something about them. So the question is, how are we making the invisible visible? There are so many aspects of our healthcare and healing journey that have not been seen or overlooked, or we kind of become blind to and we stop noticing. So this is, how do we get better at noticing so that we can make the invisible and important more visible? The third theme we call is living. How do you breathe life into your experience? How will we stage our experiences anew? How will we tell a new kind of story? How will we be the change that we wish to see? So that is a question for all of us. How will we continue to breathe new life into the experience and truly be that change that we wish to see? And then that fourth theme that sometimes raises an eyebrow for many people, we call it loving. And I think we've all felt and seen the heart of healthcare right in the spotlight for the world across the last 2 years. And loving is, as the extraordinary poet Khalil Gibran says, work is love made visible. This is a space where we have an opportunity to show up with our whole heart and to design for and with joy, bringing that joie de vivre, helping people fall back in love with the work that they chose as their profession and their career. So the question is, how does our love show in our work? And are we making sure that that's a demonstration every day, an action every day?
Okay. Anybody have anything else to add before we take some questions from our audience? I would love to thank everybody. I mean, this has been a wonderful session, certainly been for me, and I'm sure it has been for everybody in the audience. It's been very interesting. I tried to take some notes so that I could summarize it all. No way can I really do that. So I would invite you to all look, if you want to, when this comes out in video format, that you can download, that you do that, and use some of the things, or some of the thoughts, some of the strategies, whatever you hear here. There's a lot of information that's been communicated to you. And I think it would be worthwhile to go back if you have time to listen to this again and be able to maybe put this together. I don't think I can do that on the run. So,
Barbara, I'll just add to the question we're asking. That we talked about pandemic fatigue, and I think, asking me why I went into, medicine. I won't even tell you how old I am, but many, many years ago, I'm a different person now. So when we say, let's bring the joy back, I do these one thing different exercises here. What are you going to do differently? And so recently I just asked my management, the operations call, to ask themselves a different question, not why did you go into it, but why are you staying in this field? And the reasons I am getting back have been incredible. One physician said, I have the chance to make a not only meaningful, but a magnified difference in patients' lives by doing what I'm doing. And a lot of the answers are coming about the team. They love the team that they're working with. They couldn't imagine leaving the team while we still have work to do together. And so it's a different question, but I think that's what's bringing back some of this joy that you talk about. Because I don't know, if you told me 20 months ago this is what's going to be like, I probably wouldn't have taken the job, to be honest. But when I look back at why I stay, that's making a difference, and it's pushing us forward. Let's move forward. Let's not keep going back to the back. Why now? I mean, everybody can leave. If you're, and frankly, my advice to everybody is, if you have unhappy people, let them go and find where they're happy. Don't keep staying in the job and being grumpy and upsetting everybody else. There's people that want to stay and stay because of each other. And if you're one of those that isn't happy, go find your passion. But let's get back to that reason. So it's been a really exciting, and we're getting, entries coming in daily to me as to why they stay. And that's pretty cool.
That's an excellent segue, Dr. Sharif, to Amanda's question. And so please, I open this up to everybody. Can you share a tangible behavior or verbiage that you found to be useful in patient interactions to convey caring?
Well, behavior one is sitting. I mean, they get no visitors, or now it's like a tiny little visit. So imagine your COVID patients that have had nobody come to see them. And so simple behavior like sitting at the bedside with your patient. It sounds very like back to the basics of patient experience, but now during COVID, that has become even heightened. That might be their only visit during the day, right? So sitting at the bedside. And I think expressing that you understand how difficult this is, right? Even to the family, we know how difficult this is for you not to be able to come in when your loved one is dying. How many staff had to be there and be that last voice of conveying. And so I think just expressing that I understand this is difficult for you, and what can I do to make this better, within the parameters, and that goes a long way. So those are my tidbits.
Wonderful. On another note, from Carla, she'd like to hear more about what are the DE&I efforts at UCSD and Scripps specifically to address health disparities. I think COVID really shined a light on this and underscored what we sadly already knew.
Go ahead, Leslie, you want to start?
Sure, I can absolutely take this. And we have really, built upon some committees that previously existed, but the pandemic, especially around access to vaccines and the equity there, had great opportunities. So we had funding from the donor community, which allowed us to have a vaccine bus. And we were able to go out and ensure that some of the underserved populations had the right access to vaccines. There were, we amplified some of our population health opportunities with outbound calling to patients, and really had a data set we were monitoring to ensure that we had a variety of touch points of outreach to ensure that they were getting vaccine equity. And so I think we'll just continue moving these efforts forward and having champions. We're very soon having a chief administrative officer for diversity, equity, and inclusion come on board, a physician position here, which will be on the executive leadership team, and that will help us move some of this great work that's already been done, move it forward.
So the other part of that, so I mentioned the sprint teams, we have identified clear pockets of patients that will bounce back, or they don't understand what has to be done with them. Homeless is one example. And so we do have a homebound program. It's called Good Medicine, where the physicians actually go into the patient's homes, evaluate their circumstances, give medical care. That's one area. We have an acute care clinic as well. But the other thing with Press Ganey, the new survey, the new tool that they've set up, the platform can help us differentiate even more. So we can look at the patient surveys, differentiate by age, gender, race, and say, okay, what are they not understanding? So if it turns out, I'm Asian, all the Indians are not understanding the purpose of their medications, for example, then maybe we could do some focused education. And so I'm really excited about rolling that part of our patient experience work together and segmenting the groups now. Before, we just had to get to level set, right? We wanted to get everybody on the same page, and now we can start segmenting the population and figuring out what the different needs truly are. Maybe we're going in there and we're using all this jargon, and we need even the pharmacists, right? How do we train our staff to better meet the needs of our patients? So that's our next step this next year.
Excellent. So a lot of this experience information ties back into several of the comments Sonia shared about the design, and Ellen wanted to know, could you talk more about the design salons and what they are and how they are used?
Absolutely. Thanks, Ellen. There are design salons that are happening within organizations, but maybe I'll share a couple of the design salons that we hosted as collaboratives across the industry as we started into pandemic, kind of opening our experience lab doors to anyone in the industry that had a design challenge, something new that they needed to create a new experience through. We never imagined the number one request would be how to design for the loss of a caregiver. They were preparing for early on that in an organization they may actually lose one of their own team members. There was a collaborative we followed a design process, our team guided, where they had a clear desire for a process in an organization for how they would actually guide a team and a team member and families through that process. So it is a stepwise design process using principles, skills, and methods to map the experience. There were the touchless clinic is a design salon where kind of a rapid design on how do we create that touchless experience, those digital waiting rooms, surgical communication reimagined in this space. I think the other ones that have been really incredible have been virtual onboarding. How do we design for our new team members that are joining us in a time when we don't get to necessarily meet with them in person as their first arrival into the organization? So every single step in that journey is designed, created. All of the communications are created or video or virtual, whatever that might be. And then also design salons at the industry level on a healing lexicon. There was that question about both behaviors and also sort of phraseology, right? How do we actually create a healing lexicon? What are the words and phrases we will eliminate from our organizations? And what are the healing words and phrases we will be building into our lexicon? Those are big design salons. They were 6 weeks at a time. They would come two days a week to design that process. When we work with organizations specifically on their own experience design, those design salons are always a multidisciplinary team of folks representing all the different wonderful people and perspectives, and they are designing to a particular design opportunity.
Excellent. Thank you so much, Sonia. Barbara, being mindful of time, I think it's good for us to go ahead and segue in to summarize our event today. So can you take that away and then I'll close us out?
Okay. I assume that everybody in the audience, I know I certainly did, learned a lot about how the pandemic has changed so many things, but how it's an opportunity for us to do so many new things that we haven't done before, haven't done in the same way, to think about what we're doing, why we're doing it, and how we're doing it. I think there have been a number of wonderful points brought up about what the training or what things you would do with your staff in terms of having them take away from the pandemic new things, new ways that they can do things. There were a lot of things that came out like that. I took some notes, but there is certainly a lot of things to talk about. What we would never want to go back to, what changes, how we'll measure the experience in the future, whether there are stumbling blocks. It sounds like there don't appear to be too many stumbling blocks. What we do about staff that is, we call burnout, but that is working and probably initially started out feeling really good about themselves, being heroes, but then after a while that got to be a bit tiring, and how we can support them. We talked a little bit about some of the tools, talked a lot about feelings, how important feelings are, that everything that we do going forward, what we take forward has to do with, we have to think about how it feels, how the patients feel, how we feel. Building in time for our staff is very important because they're also very busy. How do we build in time for them? I remember I asked the question whether there was a tool set that was available, but basically what Sonia reminded me was that we really have to build our own tool set in terms of how we're going to handle these things. What you never want to go back to. There wasn't a lot said about that, but it does seem like waiting rooms, having waiting rooms and having everything choreographed as to how people come in and wait and so on, that we can do that without having waiting rooms, that we can be a little less intentional, if you will, about the process that we have, and maybe be a little bit more free-flowing. Did I capture that correctly? About how we do things. So we doesn't have to be perfect. It just has to be workable and good. So that we don't want to spend a lot of time on perfecting everything. I think that's what Dr. Sharif mentioned. And making sure that we build in time for our staff so that they have time, because there is a problem with burnout. I know that Sonia doesn't really like the word burnout, but there is a challenge with that, and we have to be sure that we build in enough time for our staff so that that's not a problem. And I love the thing, I'm not sure who said this, but the fact that patients now are feeling during the pandemic, the fear is that they're not relevant, that their questions are not relevant. And that we need to be sure that we make sure that they feel like everything that they're feeling, everything that they're saying is relevant, especially since many of them have not had people who could come and help take care of them at certain times. So that's important. But feeling seems to be the word that keeps on popping up. Anything else I missed? I'm sure I missed some there, but anything important that I missed in terms of summarizing? Each of you could say one thing that if you were summarizing it, what would you say was the most important thing that you learned today? Leslie, what was the most important thing that you learned from your colleagues today?
Leslie, you're on mute. There you are.
I'm sorry.
Yeah, I was having a bit of a hard time. Can you repeat that, Barbara?
Okay. What was the most important thing that you learned today from this meeting?
So I think really just ability to just know that we're all experiencing these common themes. And, Dr. Sharif and I, as she mentioned, belong in a collaborative. And so I just love the opportunity of the ideas sharing, and also knowing that in our work, no matter what organization we're in, we're all colleagues. We're all trying to, make a better experience for our team members, our colleagues, and our patients and guests.
Dr. Sharif, what was the most important thing you think we learned today?
Leslie, you've done like twice to me already. I think that you say it. And so that's exactly what I was going to say, is that we're not alone, that, we can't share best practice. It's not a competition, right? I mean, we all want what's best for the patient at the end of the day. So sharing the best practices. And I think what's really been important, as I listened to Sonia and Leslie, is consistency in our approach. We tend to do up and down, as we go, and, the whack-a-mole approach, but how do we make our staff be more consistent every single day, every single patient? And that's part of the work that we're going to be doing this year.
And Sonia, how about you? What was the most important takeaway you had today?
The most important takeaway for me is how important it is for there to be a visionary leader leading for experience, looking at these two women who are leading in such a passionate way. That these organizations are getting better every day because of that. So experience transformation does not just happen. It happens because people make choices and lead with heart and with vision. So I so appreciate the two of you.
Thank you.
And Jack, I think that's a good way to end this, because we now have like a half a minute.
Well said. I totally agree. So we hope everybody enjoys today's presentation. We'll be sending out more communication regarding our channel on YouTube and how to access today's presentation. So special thanks to our speakers and moderator. We appreciate the information and knowledge you shared with us today and your commitment to our healthcare communities. As a reminder, earlier I stated that qualified education units are self-reporting. Please report your credits by logging into ACHE account, clicking on the title, My Education Credit. In addition, if you need any technical assistance, just contact ACHE's customer service line. Again, thank you all for joining today, and look forward to more names and faces at our events coming up later this month in December. Have a wonderful day, everybody.
Thank you. Loved it.
Thank you.
You.